Okay, good afternoon everybody and welcome to this afternoon's Joint Commissioning Board. Can I start off by making some welcomes to new members? So we have Councillor Zahid Chawan, who's Cabinet Member Health and Social Care for Oldham. So a warm welcome to Zahid. We've got Dr Ash Ramachandran, who is the new Clinical Chair for Tameside and Glossop CCG, so welcome to Ash. And Craig Harris, the newly appointed Chief Council Officer of Wycombe Borough CCG, so a warm welcome to you all. Lindsay, we've had a number of apologies which I think are noted for the minutes. Noreen, you're waving at me.
Yeah, could we welcome Councillor Jude Wells from Stockport as well?
Right, okay.
Thank you.
So, sorry, you weren't on my list, so
Thank you.
I shall tell Rob off later, but a very warm welcome to you as well. So, okay, thank you. And Lindsay, the apologies are noted. In terms of Chair's urgent business, just one piece really. So members will be aware that we were planning to bring a paper today around improving specialist care. In terms of recommendations to proceed to the next stage. We've identified that further engagement work is required across the system before we'll be ready to bring that paper. So as a part one agenda item, it will be deferred until September. Okay, so let's move on. So we've got one or two process things just to get through to begin with. So the first one is appointment of JCB co-chairs and vice-chairs. As I'm obviously conflicted for this agenda item, I'm going to ask Rob to lead the discussion.
Thanks very much, Tom. So yeah, as this is near the start of the municipal year, we're running today's session as an annual general meeting, really, with a series of governance updates and annual refreshes. So as Tom said, the first one is the paper around appointment of co-chairs and vice-chairs. As colleagues will be aware, at the December 2018 JCB, we appointed co-chairs for the period to the 31st of March 2020. Tom was appointed for that time frame. So the first point is that we're to note the continuation of Tom in that role, as previously agreed. And we also have a requirement to identify a new local authority co-chair. And as colleagues will have seen through the papers, the Joint Commissioning Board will be asked to approve the appointment of Councillor Brenda Warrington to that role, who is sat here to my right. Given that we're making these recommendations here in July, the terms of reference talk about the appointments being for the duration of each financial year, but my suggestion today is that we approve these appointments for a 12-month period to the end of June of next year. The terms of reference also make provision for the appointment of vice-chairs, and with the board's agreement, work would be done by the co-chairs to identify vice-chairs from within the membership as per the terms of reference. So handing back to Tom in a moment, but to ask the Joint Commissioning Board to approve that Dr Tasker and Councillor Warrington will be co-chairs for the period to the 30th of June 2020, and that the co-chairs should do work to identify vice-chairs. Thank you. Agreed. Thank you.
To me, Lindsay, if you can note that I'm back in the chair, please. Next agenda item is membership for 1920. There's a long list of people for each locality in today's agenda. Can we just make sure that that list is accurate? Everybody, John? You can use your microphone when speaking, please.
Yes, my voice normally carries, but it puts me down as Cabinet Member Health and Wellbeing. I'm not, in fact. I'm the Deputy Mayor in Salford and also the lead member for Children's Services.
Thank you, John. We'll make that amendment for you. Any others? No? Okay, that's fine. Thank you. So moving on with further process papers. So terms of reference. So, Rob, do you want to talk us through what we're being asked to approve today, please?
Yes. Again, in the light of this being the annual general meeting, an annual review of the terms of reference. Liz Tracy and I have worked on this, taking advice from legal advisors. We have made some amendments to the terms of reference in terms of formatting, update of terminology and some other points of clarification as set out in the paper. For complete accuracy, under point in the sort of amendment sheet, the version control sheet, it makes reference to an amendment to 3.4. It should be to section 3 more generally, but that's a point of detail, and we'll correct that in the published papers. I'm asking members to receive and approve the attached terms of reference, and also to particularly note that work is still ongoing to expand the scope of the terms of reference, so that when the time comes, we've got provision for delegation of specified local authority as well as NHS commissioning decisions into this board, and that work will continue and certainly be complete in time for such an occurrence to take place when it needs to. Thank you.
Okay. So are we happy to approve the revised terms of reference, or any comments? Chris, please.
Yeah. Sorry, Tom, I'm waiting for my steam-powered computer to line up. I think it's under section 3, and it's about all CCs delegating to the JCB oversight of the process up and including the decision-making process. I'm still not clear in my mind if HMR have done it as far as the decision-making process goes, having delegated to our integrated commissioning board. I think Rob was going to clarify.
Thank you, through you, Chair. So, yeah, my understanding from previous discussions around this table is that those delegations were made at the time by Hayward, Middleton and Rochdale CCG. My understanding it was done in 2 phases. I think the first phase was to delegate the decision-making around neuro-rehabilitation, and the second phase was the remainder of the Improving Specialist Care programme. But more than happy to work with you, Chris and Steve, outside of the meeting just to double and treble check that. But certainly that's the reported, the minuted position as per this JCB in terms of that particular issue.
Yes, thank you. No problem at all with the terms of reference, but Chair, I wondered whether it would be opportune and perhaps good practice for each locality now to, I'm not sure of the significance of any changes, but for each locality to ensure that at least their statutory CCG governing body fully understand and receive these terms of reference.
Okay, so I think that's a reasonable challenge, Anthony. Does anybody protest against that? Lindsay, if we can capture that as an action that each locality will take back the revised terms of reference to their own sovereign body, which will usually be the CCG governing body at the moment, as we don't have any local authority delegated decisions at present. So, are we happy to accept those 2 recommendations around the terms of reference? Thank you. Declaration of interest. There is a blank form being circulated for any conflicts of interest you may recognise on today's agenda. If you do have a substantial conflict of interest, please let me know so that we can decide how we're going to manage it during the course of the meeting. Moving on to the minutes of our meeting on the 18th of June. Is everybody happy with those as an accurate record? Okay, no matters arising that we need to particularly pick up, so I'm going to move us away from process and on to a more substantive item. We've got about 30 minutes for this. This is going to be led by Sarah Price, our Executive Lead for Population Health and Commissioning at the Partnership, and this is very much around our Population Health Plan, where we've got to so far and what the plans are moving forward. So if I can hand over to you, Sarah, for presentation. Thank you.
Thank you very much, Chair, and hopefully we'll have plenty of time to answer questions afterwards. So I came earlier in the year and went through some of the areas where we think we've made some progress, and to give you a feel for the sorts of areas that we were working on. We've now done a bit more of a thorough review of where we've got to and why we're still a bit away from having anything completely concrete about progress, because obviously change takes a little bit of time. I wanted to bring this back to you at this point before it goes to the Health and Care Board for public consumption at the end of the month. So I'm just going to recap the scale of the challenge. I know it's always a bit depressing to have that highlighted again, but hopefully it will be useful, and then tell you a bit more about where we've been investing and whether or not we're turning the tide in terms of outcome. And then building on our population health plan, what are we going to do next and how we're going to take forward the next couple of years as we come to the conclusion of the investment strategy, including our priorities for this year. So 17,200 preventable deaths we think we've been able to achieve, and we've got a really big gap in terms of what we can see between annual income and expenditure in terms of what our populations will need in terms of health and social care. And over 1 million of our residents live in areas among the 20% most deprived. So none of this is new, but I suppose one of the questions we've got to ask is what we're doing making a difference. We've got 236,000 people who are out of work, and 150,000 of those are out of work due to health reasons. So these are things that we are targeting in our population health plan. And in the prosperity review that was published in February, poor health was identified again as one of the main contributors to failure to achieve some of the growth that we would have anticipated, and why perhaps it's been slower. And in addition to that, we've been doing some analysis which suggests that some of the growth that has occurred in GM, although it's taken place, hasn't had a health benefit to the same extent that other places have seen. So, for example, Liverpool City region have had a much more direct relationship between growth and health improvement. They haven't seen as much growth, but it's been more directly related to health. So that's one of the areas where it'd be really useful for us to start to look to see whether or not we can make a difference. So these were the 24 programmes that fitted within the population health programme, and the report that you've got attached to today's papers goes through each of those in a little bit more detail. It sets out what we think we've achieved, some of the challenges that we've faced in trying to deliver those programmes, and where we're going to go next and what we're going to focus on. So I'm going to give you a few highlights. But recapping again, we had £30 million from the 450 of transformation funding dedicated specifically to population health. But of course, in each of your localities, you will have been doing things and put some of your own locality plan money into population health benefiting pieces of work. So 30 million is the specific allocation, but of course it's much greater than that. So these are the areas where we've invested over £5 million. And you'll see that some of them are very obvious, like tobacco and alcohol, etc. But we've also invested things like getting people back into work or keeping them in work, because we see this as a fundamental contributor to overall health and well-being. So we've tried to take as broad a view as we possibly can. So we also received £10 million from Sport England, and each of the localities is working up what they're going to spend their share of that money on in terms of reducing barriers to physical activity. Although we put £4.5 million from this fund into early help for helping people to remain in work, the Combined Authority and the Work and Health Unit, the European Social Fund, also put another £4 million into that project. So we've managed to match fund that money. And we've also had £2 million from the cancer programme in order to roll out the CURE programme, the tobacco in hospital programme, which I'll tell you a bit more about. So just starting at the beginning with starting well, we think that we've got 200 more children who've started school with a good level of development compared to 2017. Now, there's an awful lot of work that goes into that, and our work isn't the only contribution, but the £2 million from the population health plan that's gone into trying to ensure that we've got the right kind of support, the 8-stage programme that many of you will know about, that's really up and running and working, has been an important part. So 11,800 children reach a good level of development by the end of 2018. That's about 68%. We've had real improvements for disadvantaged children and for those who are on free school meals, which is quite a good indicator, as many of you will know, for whether or not somebody needs additional help and support. And we've improved that by 7 points since 2015, which is no mean feat. So I think we'll see a much bigger impact over future years, but as those children start to reach school age, so as they age, and come into school, I think we'll see the benefits in how they do in terms of development at school and learning and outcomes from school. But at the moment, that's looking relatively positive. In terms of oral health, you'll know that this is one of our key indicators of whether or not we've got good child health within GM. And we have got areas that have exceptionally poor rates of decayed, missing and filled teeth. And because of that, we focused on those with in the worst position, so Bolton, Rochdale, Salford and Oldham. And although we've been doing a programme across the whole of GM, because not everywhere's fabulous, we've been working across the whole lot, but we are seeing some improvement in dental decay. And that's partly through some of the experience at school, but it's also in terms of the number of children that are visiting the dentist. So we've got 4,000 additional children who visited the dentist since the programme began. And that's one of the challenges, people understanding that having your teeth checked before they start to hurt is a really good thing to do. And baby teeth do matter. They do affect how your secondary teeth come out. So, making sure that you look at all of those things is important. So that seems to be moving forward. We think we've had an additional 250 smoke-free babies. Our number of women smoking at time of delivery has improved from 12.8% in 2017 to 11.7% in early 2019, and so that's a quicker improvement than in the rest of the country. You could argue we've come from a worse position, so but nonetheless, it's really, really important, and supporting and making sure that the work we're doing in each locality to maintain this work is really key. So when looking at what's happening around smoking cessation support or whether changes you're making to your programmes locally, I would ask you to reflect on whether or not these programmes are being supported and protected at a local level. Moving on to working age, we are on track to make smoking history, and these are probably the best data we've got in order to judge whether or not we're improving. The national data has just been published, which suggests that our smoking rates have fallen to 16.2% from 18.4 in 2016. That's also backed up by some of the additional data we've been collecting locally, which means that we are improving faster than England, with 2.9% gap down to 1.8%. So I think we are beginning to see real improvement in smoking prevalence. And CURE, the hospital-based support for people who smoke, has kicked off at Wythenshawe. We hope to roll it out to another 6 hospitals as the year progresses. But in the first 6 months, we managed to achieve a 42% stop smoking target, with national or other programmes only around 35%. So having that really focused effort is really important, and we're seeing a lot of that being sustained at 12 weeks, which isn't measured elsewhere, but is something we're able to look at. So I think this is something that we really would encourage localities to really focus on when people have it within their locality. Physical activity, we've seen a real improvement too. Around 67,000 more people were active in 2018 than in 2016. We've got large numbers of schools joining the Daily Mile programme, and one of the Mayor's key strategies. We've got new schools involving at a rate of 3 per week over the last year. So really challenging that is something that we've put a lot of effort into, and I think we'll need to continue in order to really reap the benefits in the longer term. One of the smaller projects, but perhaps really important one, is the work we've been doing on malnutrition and dehydration in older people. And this was a piece of work that started in Salford, but we're rolling out to other areas and has been led by Age UK. So this is something that's not about a clinical intervention. It doesn't require a professional service to do it, but volunteers, family members and others can get involved, and involves putting a piece of paper which is marked up around someone's upper arm to see whether or not there are indications of malnutrition or dehydration as a result of shrinkage. And we've managed to train up about 1,000 care workers now, and they're using these armbands. But we think that almost 300 have been found at risk, and 2/3 of those gained weight over a 12-week period. So it's about helping them to get support to be better nourished, etc. and a further 25% stabilise their weight. So it does seem to have a real impact and something that could easily be rolled out across the whole of GM. So those are some highlights from the plan itself. But I suppose one of the things to emphasise is that we've tried to look at what will make a difference at population level across the piece. And through some work we've been doing, we've been looking at what creates a strong population health system. So yes, of course, behaviours and lifestyles are very important to that. But also those wider determinants, whether you've got a good job, whether you've got somewhere warm, dry to live with a tenancy that is safe, whether or not other public services are joining together to deliver a rounded approach to your needs, and also whether we're taking a person-centred approach at place level. So all of those contribute to a really strong population health improvement system, a virtuous circle, if you like. And we've tried to look at what we're doing in each of those areas to improve our coordination of the work that we're doing. And then some of the work that's happened over the last 6 months or so, the prosperity review, the work that's been doing at the moment on the GMSF, our spatial framework, what we're doing in terms of the development of the public service white paper, all of those will help to contribute to that overall population health system, the housing strategy, etc. In terms of inequality, we're doing this piece of work with Michael Marmot from UCL to look at our policies and what we're doing across the piece to see whether there's more that we could be doing to try to drive down that inequalities gap for Greater Manchester, and whether or not through some use of more focused metrics we could monitor our progress in a more immediate way so that we can start to intervene when appropriate. That will cover the breadth of what we're doing in GM, not just health issues, health projects, but look across the whole piece. That's something we're very keen to move forward on. And then finally, what are our priorities for this year? So obviously we want to continue to deliver on the population health plan, but we also want to further shape our thinking about our ambition across GM, thinking about how to make the system work better, how to develop our population health leadership. All of you in this room play that role, but who else do we need to bring alongside in order to be able to do that? We need to make best use of the tools and levers that we've got. So, for example, at the end of 2017, the Combined Authority was given powers over public health order by Parliament. We haven't really used that for anything yet, so we're doing a piece of work at the moment to see whether there's anything additional that we could be doing using those powers that would allow us to really move forward at pace. We're also looking at strategic investment. We've been very lucky in GM to have this £30 million, but what happens next? Hopefully there'll be a commitment to investment across the piece at some point in prevention, maybe coming out soon from the long-term plan, but who knows? But there are other kind of ways in which we could look, social impact bonds or other ways of incentivising investment in prevention in the way that we set up our contracts, for example, in the way that we work with the community voluntary sector. Is there more that we could be doing to bring investment into Greater Manchester that would take a more preventative and early intervention approach? And then obviously there are the long-term plan ambitions, which I think probably we've encapsulated already in much of what we're doing, but it's worth having a look to see whether there's more we could do. I think the role of the anchor institution particularly might be something we want to look at. Some of our big organisations, we're big employers, what's the social value that we could bring to bear to reduce the impacts of poverty and deprivation. And then finally, working with all of you and the Mayor, the Gmca, to think about some of those wider determinants of health, those social determinants, so air quality, housing, spatial planning, healthy and sustainable economic growth, picking up that issue that, you know, we've had growth in Greater Manchester. Have our population really benefited as much as they could possibly have from that investment? So we'll be looking at that going forward. And I think, thank you very much, that's everything.
Okay, so well done, kept to time, which is good. Remember turn the microphone on. So, any comments, queries or questions for Sarah, please? Zaid?
Thank you very much, Sarah. It's obviously great work. I'm just wondering if we know that among GM we have some localities, and within localities we have actually hotspots. So, say for example, in Oldham we have an 8-year difference between one part of the Oldham to another part of the Oldham. Just wondering, part of your overall review, did you see any data or anything whether it has made difference in those localities, in those hotspots, whether they are benefiting from the interventions as well, or these are the outcomes of sort of like generalized population?
So some of the programs that we're running are, as I mentioned, the oral health one is running in particular areas, so it's much more targeted at those in greatest need, and others are universal. So we've got the differences in the programs that are very much more targeted, but other than that, things like smoking data is probably the best data that we've got, and the smoking toolkit data will give us some feel for whether or not we're delivering in the areas that are most struggling to reduce smoking prevalence. But the most robust data is the national data, which you only really get at GM level. In fact, nationally, it probably wouldn't have normally been delivered at GM level. So that's the best data. So I think some of the evaluation that we're doing will give us more sensitive kind of feedback on what's working. But I think some of that will be because we're targeting those populations most in need. So proportional kind of approach, universal approach.
Okay, thank you, Sarah. Ash, please.
Sarah, thank you for a really fantastic report, and I can see the work that's been gone into that. And especially, I just wanted to focus on the smoking prevalence, and a lot of work has been done on that. I just want to check. If I'm sure it's probably already been thought of. Is there any work being done on smoking, reducing smoking, smoke-free school zones? Because one of the challenges is that this normalizes the younger generation to, when they watch the smoking adults, that it normalizes the next generation to take up smoking much more easily. So is that being worked on, or is that being considered?
So we are looking at whether or not we can extend smoke-free. So one of the things that we might want to ask for is further powers to create smoke-free spaces. I have to say that schools weren't top of our list, because I think we probably made an assumption that most schools wouldn't allow smoking anyway. But I mean, maybe that's wrong, and that's something we can look into. One of the pieces of work we are doing at the moment is smoke-free homes. So whether or not there's more we could do there, particularly in social housing, whether there would be working with the Housing Association Network or others as to whether or not we could introduce that in any way. And as part of the spatial planning, whether there's more we could be doing around restrictions around smoking. Parks, etc. There was a lot of support when we did our Making Smoking History survey last year for extending smoke-free spaces into parks, especially where children are playing, because people feel that children shouldn't be exposed to secondhand smoke. So that's something we've been thinking about, and we're running some smoke-free events over the summer to see whether or not councils would be more supportive of rolling that out without having to go through legislative procedures. But I think there is some appetite to do more, but I think it would be largely through us agreeing together that this would be a good thing, rather than necessarily going through a legislative kind of phase.
Thank you. Warren, please.
Thank you, Sarah. It's really great to see this emerging evidence of the benefits of this program, particularly with working with the early years. Because I think that's where our opportunity is if you're going to make a meaningful difference in our health inequalities. But my question was about what you touched on. We've been very fortunate having this transformation fund, which has been a fantastic opportunity, and all localities have used that in a number of ways to impact on this work. It's what next, really. So this opportunity is going to disappear shortly, and are there some conversations taking place in terms of how we're going to sustain some of these really key pieces of work And we should be thinking about that now, shouldn't we? So that's my question, really.
So yes, definitely we're having those conversations now. So we've in fact got a workshop next week to look at investment to see whether or not we can use other forms of investment in order to incentivise prevention and early intervention. I think there are some areas that of our work that might be kind of attractive. So some of the work around sustainability, for example, I know it's wider determinants, but clean air and all of those kinds of things might be the sorts of things that would attract external investment from in the form of social impact bonds and things like that, because you might be able to show a return on investment. Or something like the CURE programme might be something we could set up in such a way that we could attract inward investment. But for the most part, I think it's going to be about whether there's anything specific that comes down through the long-term plan, and whether or not we will be very ready for that in terms of what we've done already, but what we then need to invest in going forward. And also whether or not the evidence is showing that we get a bigger return on investment in some of these areas, and whether or not there are choices that we will all have to make about whether or not we're going to commit up front to prevention over and above perhaps other things. So what I'm hoping is that we will have more and more information in order that people can make those decisions. But I think the commitment that we made in taking charge to making population health the heart of what we do, we've really got to take forward as part of the next set of challenges we set ourselves up for. And if there is TF2 or whatever, then I would hope I'd be making a very strong case with all of your backing for investment in prevention.
Okay, thank you. We've got 4 people who want to come in now, 5. I'm going to use Chair's prerogative, though, and come in myself. So, in this room, we've got over 20 organisations, and I'm thinking, how can we contribute to this agenda? So, we're all employers of people, so there's things that we can influence. Physical activity levels amongst our staff, we can actively encourage that. We can have specific times of the year when we focus on activity levels. We can promote smoke-free premises, so that the grounds are not, people are not able to smoke in the grounds of civic centres, for example. And we can also make a commitment to be not only real living wage employers ourselves, but also in the services that we commission. So I think one of the challenges I'd like us to think about and perhaps to take forward is how we can contribute to this, because the public sector is a large employer across GM. Okay, I've got Jane next, please.
Thank you. I just wanted to pick up on the point that you made. In Trafford, we're actually starting a pilot in September, smoke-free school gates. So we're going to, the posters are ready to go, so they're all going to be put up for September. And we're going to work with parents who want to try and quit smoking. So we're already trying a pilot, so it might be some information that we can feed into you from that later.
Stephen next, please.
Thank you. Well, mine was building on Warren's point, really, but this is the point about sustainability, and so I think our biggest challenge is sustainability, we will attract more money externally, but fundamentally taking charge was about actually how we shift the investment model on the £6 billion into an early intervention prevention model, and I think that's got to be the challenge of this board. That's what this board should be about. Actually, it will do other things, but fundamentally it needs to think differently about the investment model. And I think, that's what Sarah's challenge is for us. That's what we should be doing. We will do social investment bonds and all the rest of it, but actually, fundamentally, we've got to look to ourselves, I think, in terms of how we spend money.
I mean, the other kind of bit that I didn't mention was the, if it ever happens, the CSR and nationally what our ask would be, and we're working across the partnership with the combined authority, etc., to look at what the population health ask, what the unique population health ask would be as part of that spending review. So going straight to Treasury and making the case for, I think, inclusive growth, to be able to say that unless we improve the health of our population, we aren't going to benefit in the way that we need to, because that's what, understanding what the Treasury want us to do in order that they might invest in GM, we need to be able to show them that by investing here in health, they are going to make a difference, along with lots of other things that we'd like them to invest in. But it's definitely a case that we're starting to make.
Okay, thank you. Keith, please.
Yeah, it's just along the lines that Sarah finished off on, where she was saying about the investment and the benefits to communities, and certainly you went part of the way along that. But I'm just starting to think that if you look at the Preston model, which is an economic model for a local economy, I'm just wondering, with the amount of money that we invest and that we spend across here, whether we should actually be looking to generate social value and community wealth building around the communities, which will help in terms of sustainability, because it will then enable another asset that we have, which is the 2.8 million people here, to actually be able to develop and actually have an impact on those more wider determinants that will significantly improve things. So I'm just starting to think, how should we, and it's probably not just necessarily us as a joint commissioning board, but it's GM wide, on economy and skills and all that, that we actually need to start thinking about that and thinking about community wealth building.
Okay, that's a great point, Keith. And I've got three more people who want to come in. So, Sarah, one of the things I'm going to suggest is that we try to capture the key points that people are making, and that we perhaps bring this back to maybe a JCB executive as a short paper, so that we can then, as 10 localities plus partnership and combined authority, look at what commitments we can make. Because what I don't want to happen is to have a discussion today and then we come back in 6 months and actually we've not moved anything on in terms of how we might have done. So I've now got the three Johns, and I've written you all down as John, so I've got to remember the order. So I think, John Roush, you were first.
So first of all, I want to strongly echo the points that Stephen and Keith made. That there is, for me, over the next 6-9 months, I think a point of decision in terms of the extent to which we try to think about the next 4 or 5 year period through to 2024 as bending that curve in terms of how we invest and how we spend our money. But a couple more points for me. First is that I think Sarah's been very clever in her stewardship of this programme, in first of all making a relatively small amount of resource go a long way, but also in terms of the way that she has stretched the implementation of the programme through to March 21, which gives us a bit more time in terms of thinking and making that transition. We can do it to some extent incrementally. We don't have to do it all at once. But what we mustn't miss is the opportunity over the next 6 months in terms of the refresh of the locality plans and also the development of our delivery plan for 2020-2024. I think we are in a relatively benign environment here, in that I think we've got a regional director in Bill McCarthy who's going to be appraising our delivery plan, who is hugely sympathetic and aligned in terms of his values to the agenda that we would want to pursue and the emphasis we'd want to put on reducing inequalities and on so promoting a population health model. So, and that would not be the same in most regions in the country, quite frankly. We would be expected to produce a vanilla response to the LTP that was all about NHS standards. I've had the conversation with Bill. He's not expecting that from GM at all. He knows we've got to cover that off, but he's much more interested in the wider sort of endeavour as well. So we've got to make sure we make the most of that opportunity. My final point, though, is about national politics and about boxing clever. And I realise the danger of making this comment with politicians in the room. But if we are going to have a new Prime Minister, and let's just assume for a moment that it is Boris Johnson, then he's going to be coming at this agenda and thinking about it from a libertarian perspective, because that's who he is. Actually, it's his single most significant consistent value that I can find is that he's a libertarian. So going to him with a model that is unduly statist is not going to cut any mustard. And particularly if you've heard Liz Truss, who's one of his biggest supporters in the last few weeks, she talks a lot about human capital and about utilisation of public spending to mobilise human capital. And I think we can work with that, actually. I think there's a way of reframing the way that we think about the world, an asset-based approach, social value, that actually speaks into that space. So I think we've got some translation to do over the next couple of months in the context of our delivery plan that speaks not only to our own values, but those of an incoming government as well.
Okay, thanks, John. Very helpful context setting. John Merry next, please.
I don't know if I'm supposed to reply on behalf of the politicians in the room, but because I actually think there's a great deal of sense in what John says, and I just want to illustrate it by the fact that in my area, some of you may know I represent the ward of Broughton in Salford, which has got some interesting characteristics, one of which is the largest Haredi Jewish community in the whole of out the country outside of London, right? And one of the others is that it had an incredibly low rate of vaccination prior to the recent outbreak of measles. And just taking on John's point, I think it is about working with individuals. That's one of the strengths of devolution. So what we did in Broughton was worked with the local rabbis to persuade more people to vaccinate, to say that there was nothing inherently evil about being vaccinated. All of that, I think, was very effective in helping to stem the tide in terms of the outbreak that was happening. And this brings me on to the further point, which is we can be proud of what we're achieving in smoking cessation, but I do take Sarah's point on board that telling somebody who hasn't got a job and hasn't got a decent house that, by the way, it's time to stop smoking as well, doesn't always, strike the most effective chord, actually. But one of the things that does strike me is when I talk to people in my local community, the number of people who said, well, I've smoked for 30 years, it's too late to stop now, I've done the damage, it's not going to be any help to give up. And I just think one of the messages we need to focus on, right, is a key message about if you stop smoking, you will immediately see some benefits in your health, irrespective of the long-term damage that you might have done. And it is about, I think, relating to John's point, about seeing the individual as an agent for change rather than just simply trying to impose something on them.
Yeah, that's a really good point, John, about trying to bring it down to the individual level and what the benefits will be to them, which is an interesting challenge sometimes, especially when people have spent most of their life smoking, and we're trying to get them to think differently. John Patterson, please.
Thanks, Tom. So 2 quick points, but first of all, just to say that obviously we're very supportive of this programme, a big fan of population health in Oldham. You won't be surprised to hear. I spent this morning with our practice managers, and when the conversation turns to money, they'll echo Steve's point. They'll say, if you're spending £1,500 per head of population, why are we just getting £86 a head in primary care? And it's not to say that that's a grab for more money in primary care, but it's that idea that we have to rebalance where we're spending the money. And for me, I'm increasingly convinced that it's not just about prevention, but it's about secondary prevention, because that's where the magic is in GM, that we have enough people who have already got established conditions and we're not getting to them. That idea that the core business of primary care absolutely will affect population health. And so the question, Sarah, is that there was a little sliver there about health intelligence, and I just wonder what are the fruits of that, and are we getting into that part of the world that we're learning from the Marmot cities and we're learning from Michael, that secondary prevention is where it's at, and are we identifying people who have got established conditions who have yet to be matched up with self-care and with the care that we do provide?
So just taking that last point, one of the programmes that we're really looking at is the health checks programme, because we spend a lot of money looking at people who, to a large extent, know if they've got a condition or that they're relatively healthy. By the figures that we've got, we know that we're missing over 50% of the people who have got needs and aren't being picked up by services at the moment. So what we want to do is to refocus the programme onto those at highest risk and to start to segment that population. So we're doing some work in Salford, in Manchester and in Trafford on using their data to see whether or not we could start to call and recall people at highest risk first, and that we can create a digital offer for those that perhaps have lower risk but want health, need support. Taking a bit of negotiation with Public Health England to do that, but we're hopeful that we'll get that off the ground shortly. But I think there are a number of areas like that where we can support around secondary prevention, and I think in the long-term plan where we've got investment coming down the pipeline for particular areas like diabetes or whatever, I think that we've got to make absolutely the most of those areas to be able to pick up on people who are at risk and manage them. Hypertension's another thing. I think we should be really looking at atrial fibrillation. I'm sure there are things that would resonate in each of your areas as to what we could do. So let's think about that, yeah.
Okay, thanks. I've got two people who want to come in, and I'm going to close this agenda item down because we've had a really good discussion, but I do need to move things along. So I've got Ian, then Anthony, and then we'll close, please.
Thank you. So first of all, thank you for the report. Some really positive news in there. Smoking cessation rates, especially City of Manchester, we're delighted to have seen a reduction from 22% to 17.2%, which is a phenomenal decrease in the city, which we're delighted with. Want to support your suggestion, Tom, of a follow-up report which links to other comments about us taking a very clear and collective approach together as a JCB. I think that links to some of the values discussions which have been raised, and I remember back, if this is our AGM today, I remember back to what may have been the equivalent of the AGM last year, where we individually and as localities described what we really wanted to achieve as a JCB together. And one of, if not the most prominent themes in that, was reducing health inequalities within and across Greater Manchester. So as we look at a report about what we do next with probably less resources, I think that focus on our most deprived, our most unequal parts of Greater Manchester, my instinct is would get great resonance from Manchester and hopefully from colleagues around the table. Thank you.
Very good points. Thank you. Anthony?
Yeah, just quickly, I completely endorse the point about ensuring that our locality plan refresh has a population health-driven approach to it. I think we would be wise to all consider that type of approach. And equally, the question of prioritisation as well going forward. I think we should have a debate about the public health functions order as well, and what might be the scope of the possible here for us. And I finally just would urge that a lot of these population health issues are issues to a certain extent that we're living with now. One of the things that we mustn't forget in this space is the challenge around climate change, which has the real potential to make the health and other inequalities that we already suffer much, much worse. And so we must ensure that we give strong and active consideration to the possible future impact of climate change in this particular agenda.
Okay, thank you very much, everybody, for contributions. Eamon, do you want to say something quickly?
Very quickly. Slight note of caution around the orders and the powers. Can we focus on what is the important rather than the art of the possible? Because I think it would be easier for leaders to have a conversation about the exercise of powers by the CA if we're being specific about what it is we are seeking to achieve. And just so that rather than having a conversation in abstract around powers, it's just something that might help us move forward more quickly.
Okay, thank you for that point, Eamon. So, Sarah, I think undoubtedly there's a lot of interest, a lot of passion in this area, and something that I know from speaking to colleagues that the Joint Commissioning Board is really interested in taking a grip on and contributing to. So are you happy to bring something back and a sort of action plan perhaps arising from today's discussion so that we can then look at the tangible benefits of having a 45-minute discussion there. So thank you very much, Sarah. And it's back to Sarah. Okay, our last agenda item is the Gynecology Cancer Surgery Service Specification, which is hopefully a relatively straightforward paper for you to present and ask us to approve the recommendations.
So this is an area of work that John, as Chief Officer, has specific responsibilities under the delegations from NHS England to approve, but is something that we want to increasingly do within the context of the Joint Commissioning Board to ensure that everything's tied together. So on that basis, this paper sets out the work that's been ongoing on the decision that was made by commissioners probably 2.5, 3 years ago now about the shape of a single gynecological cancer service for Greater Manchester. In terms of what will happen for patients, the two providers currently will continue to provide, but what we will be asking them to do is to work in a joined up way as a single service, with the lead provider being St Mary's at the Manchester Foundation Trust, supported by the key provider, the Christie. At the moment, the way patients flow into both of those trusts is via geography. So if you're from one area, you use one service, and if you're from another area, you use another. What we're asking them to do now is that referral routes would be as they are now, but would come into a supra multidisciplinary team where all clinicians would contribute, and you would receive the treatment from the either the Christie or St Mary's, depending on what your needs are. They roughly offer the same service, but there are some subspecialisations, which would mean that you might want to see the surgeon at the Christie for your particular problem rather than a surgeon at MRI or vice versa. So the idea is to both use capacity to its best effect and be most efficient, but also most importantly to offer the very best care to our residents. It would also mean a more joined up approach to research, and so entrance into trials, etc., would be more effective. So the specification, unlike some of the other areas of work, they started doing the work first and they've written the specification having worked out how they want to work together. So hopefully it makes sense, it reflects the best way to use the resource, and hopefully will mean that we continue to improve in terms of our outcomes for women with gynecological cancer.
Okay, thank you, Sarah. Any questions? Ruth?
Thanks. It's just a query really. I think you've explained it, but obviously there's different expertise about the urological and the bowel reconstruction, which is done at the same time in theatre. So I think what you're explaining is that will be factored in at the point of allocation to which unit.
And if there's a procedure, for example, at the moment, there's no robot on the MRI site. So if you needed if robotic intervention would be the best thing, then that would be done on the Christie site. So that's the whole point, really, to try to make sure that everyone has the opportunity to have access to the very best for them.
Okay, just a quick question for me. Does this proposal have the support of the clinical teams who are working in the two separate units at the moment? And we're going to evaluate after 12 months. So how will we know if this has been successful in 12 months' time? I suppose, not necessarily asking for the detail, but just to be clear that, you know, what can we achieve within 12 months to know whether this transformation has been successful?
So I think for the most part, the clinical teams are happy. I think there's been really good leadership, clinical leadership in this particular space. There are always people who will find it more difficult to change the way that they work. So I wouldn't like to say it's 100% happy, but I think we've got to a place where both organisations are working together to make the best for outcomes for patients. In terms of 12 months' time, I think it would be whether we've got the Super MDT up and running and whether patients are flowing through that. That will tell us whether or not we've succeeded. And I think we will, as that beds in, I think we'll get real economies of scale and efficiencies for working in that way.
Okay. We finished filming now.